Hello, this Pathophysiology 2 recording will be discussing arterial hypertension. So what is hypertension? It is high blood pressure. High blood pressure can exist in different vessels within the body, but the most common form is arterial hypertension. So within the arteries, high blood pressure within your arteries. So if you've had your blood pressure taken in the past by your doctor, what they're doing is they're measuring the blood pressure within your arteries. We can define hypertension or high blood pressure as consistent, oftentimes chronic, meaning that it's not as common for it to just suddenly be higher, but more likely that it's been ongoing for quite some time. So chronic elevation of your systemic arterial blood pressure. And so what do those numbers look like when they're measured? Well, we're going to be looking at both systolic pressure and diastolic pressure. So whenever your blood pressure is taken, it's recorded as two numbers, and it written down would look like a fraction where you have the systolic blood pressure as the top number and then the diastolic pressure as the bottom number. The systolic blood pressure indicates how much pressure your blood is exerting against the artery walls when the heart beats. Diastolic pressure is the opposite. It's indicating how much pressure your blood is exerting against the arterial walls while your heart is resting, so in between beats. And so hypertension would be 130 millimeters mercury or more over 80 millimeters mercury or more. So anyone with a reading such as 130 over 80 or greater numbers is considered to have hypertension. We'll look at that a bit more on the next slide. Now, a lot of people that have hypertension are going to have increased amounts of collagen within their blood vessels relating to the atherosclerosis. And this increases the pressure within because you lose the normal vasoconstriction and vasodilation abilities of the vessels. So the blood has a harder time moving through it. There are three main types of hypertension: primary hypertension, secondary hypertension, and isolated systolic hypertension. Primary hypertension is also known as essential or idiopathic, and this is the most common. So most people that have high blood pressure have primary hypertension. We know idiopathic means of unknown cause because in a lot of cases you can't pin it to something very specific. Primary hypertension is strongly influenced by genetics, but there's a major increase in cases relating to environmental or lifestyle. You could indicate that there too, lifestyle factors. Secondary hypertension is caused by some sort of disease that the person has, a systemic disease that is going to cause high blood pressure. So maybe somebody has a systemic disease that raises their cardiac output, so the amount of blood that's put out into the arterial circulation. And the more volume, the more pressure. Always remember that whenever you increase volume, let's say volume in the blood vessels, you're also going to be inevitably then increasing pressure. So there's a direct relationship there. Or if there's a disease that increases peripheral vascular resistance, what is that? Well, I told you already that as blood moves through our arteries, some of the resistance it experiences is from the wall around it in its periphery. So if there's some sort of systemic disease that the person has that creates more resistance for blood moving through the arteries, it can lead to hypertension. Most cases of secondary hypertension, though, are related to a kidney problem, but there are also tumors that can affect the adrenal gland, whether it's the cortical region or the medullary region, and then certain drugs can lead to secondary hypertension. Finally, isolated systolic hypertension. This is where, as the name suggests, there's an elevation of systolic blood pressure, but the diastolic pressure is still considered normal. Isolated systolic hypertension is becoming more prevalent actually in all age groups, and there is a strong relationship then, or association, between people that have high systolic blood pressure and cardiovascular as well as cerebrovascular disease. So systolic measurement then where I said that's the pressure your blood exerts against the artery walls when your heart contracts, is a really good determinant of overall cardiovascular health. So just to go back for a quick moment to primary hypertension, just to acknowledge that this is not due to a medical condition. It's not the result of a medical condition. This form of high blood pressure you would see in people that are obese, people that have maybe a family history of high blood pressure, people that have a very unhealthy diet. And the great news about primary hypertension is in a lot of cases, it can be reversible with medications and or lifestyle changes. So I want to point out a few more things about hypertension, and when we look at these numbers, we're looking at from age 18 and older. So it's a bit different with kids. Normal is going to be considered less than, really, or equal to 120 over 80. So systolic over diastolic. Once you get above that point, it's considered elevated, but it's not considered hypertension. But we know once we get to that 130 mark over 80, we're into stage 1 hypertension. Once we get to 140 over 90, so greater to or equal to 140 over 90, this is considered stage 2 hypertension. Not a good place to be. Now, what's interesting is that prior to 2017, 140 over 90 was considered hypertension. But now we know that it's 130 over 80. And any medical doctors that you speak to that have not read that there has been a change in these recommendations would tell you 140 over 90. But 130 over 80 is the start of hypertension. And we can see here, this is older that I've brought up, that hypertension was once thought, not that long ago, to be 140, or begins at 140 over 90. But this one here is the more recent, where hypertension begins once somebody has high blood pressure equal to or greater than 130 over 80. A hypertensive crisis is a medical concern, a big medical concern, medical emergency, where somebody's blood pressure is exceeding 180 over 120. So let's look at primary hypertension and a bit of the pathophysiology, and I'm going to talk about a few key themes. Primary hypertension, we know, is the result of really this complicated interaction between our genetics, but also our environment and our lifestyle choices. And ultimately what they do is they increase peripheral resistance. Again, the resistance that blood has moving through your arteries because of the walls of your vessels in the periphery. So we got a few variables here to talk about, starting with obesity. Remember that fat cells are called adipocytes, and adipocytes make up fat tissue, which is called adipose tissue. And adipose tissue releases a specific type of cytokine, remember that term, cytokine, that is called an adipokine. And adipokines are molecules that play a role in inflammation as well as insulin resistance. What's insulin resistance? This is where your tissues, which we want to take in, especially your muscle cells, we want those muscle cells to take in glucose, and insulin helps with that process. It's like the key that opens up the door to allow glucose to leave the blood and enter the tissues, so it can be used for metabolic processes. But people that are obese are more likely to experience insulin resistance, where you can think of your muscles as being resistant to insulin. And if they're resistant to insulin, then glucose has a much harder time getting into the cells. What's interesting about adipokines is they contribute to this obesity-related low-grade state of inflammation. And so it's almost like people that are obese, their body's in this chronic state of inflammation. It's low grade, but it's still present, and it can predispose that person to a variety of different health conditions, some less serious than others. But in any case, any of these variables, the body can respond with vasoconstriction, the vessels constricting, becoming smaller. So if this is the diameter before, vasoconstriction would make it smaller. And so if you look at that, it's going to be obviously more difficult. There's going to be more resistance in the periphery against the walls for blood moving through that vessel to get to where it needs to go. So that's that increased peripheral resistance. This increased peripheral resistance from the vasoconstriction is going to lead to sustained hypertension. So blood pressure that remains high. Over time, this high blood pressure can cause many different things, including vascular remodeling. This is where sclerosis or hardening can occur. Atherosclerosis can be promoted, and this can lead to negative health effects. Let's look at another variable. Dysfunction of the SNS. Remember the sympathetic nervous system, a division of our nervous system that is involved in our fight or flight response. And so if you think of what signs and symptoms you'd have when you experience a fight or flight response, your blood pressure is going to go up, your heart beats faster, your breathing rate increases. And one of those events is vasoconstriction, because vasoconstriction increases your blood pressure. And that's intentional with sympathetic nervous system responses. We want our blood pressure to go up when we're in a fight or flight situation. But some people have dysfunction of their sympathetic nervous system. It's almost like it's overactive. And so they're getting vasoconstriction when they shouldn't, leading us down the same path as just discussed. RAA. Thinking back to normal anatomy, and I talked a bit about this in Altered Physiology 1, this is our renin, angiotensin, aldosterone system. This system, if we just summarize what it ultimately does, is going to tell your kidneys, don't get rid of salt and water in the urine. Let's keep it in the blood. Put it back in the blood. And when salt goes back in the blood, water is going to follow. And if we're adding more volume into our blood vessels, that's going to increase pressure. So we've increased the blood volume, which increases the pressure. And so some people have overactivation of this renin, angiotensin, aldosterone system. It's working when we don't want it to. In addition, somebody may experience, that contributes to their high blood pressure, dysfunction of natriuretic hormones. Normally, natriuretic hormones will actually encourage you to get rid of excess salt and water, but if they're not functioning properly, then it can cause the opposite to occur, where we're not getting rid of enough, we're holding on to it, having the same effect. And then there's just general states of inflammation that can cause various different effects in the body, including further dysfunction of the systems that I just spoke about. And obesity can also cause dysfunction of these systems that I spoke about. And in any case, leading us to many potential issues relating to different regions of the body, which I'll talk about next. I'm not going to spend too much time on this slide, but those with complicated hypertension, as we just spoke about, are going to have effects to various organs of the body. The blood vessels are going to be more likely to form atherosclerotic plaques. The microcirculation can be damaged, so at the level of the capillaries. Predisposition to aneurysms, your aorta can actually dissect and tear, and bleeding can occur. The heart can be affected because there can be a reduction in coronary blood flow to the heart muscle. The left ventricle which pumps blood to the entire body, can get larger. We talked about hypertrophy last term. If it's larger and it's working hard, it's going to need more oxygen, but it's not going to be able to get it. This can lead to chest pain, angina, myocardial infarction. It can promote coronary artery disease, and congestive heart failure, which is a term that will be talked about in another lecture. People with complicated hypertension are more likely to suffer a transient ischemic attack or a stroke. If they do have an aneurysm, it's more likely to rupture in the brain. They might form clots within the brain. And because of all of these changes to the cerebral tissue, it can lead to cognitive decline. People with high blood pressure are also more likely to have disease of the vessels within the eyes, which can impact their ability to see. They can have hardening of the vasculature within the eyes. They can suffer bleeding within the eyes, as well as exudation, which retinal exudates are just lipid residues that, because there's excess fat in the vessels, they can leak from damaged capillaries and then cause damage in the area. And then the kidneys can be affected. We talked about glomerulosclerosis last term, so hardening of the capillary, which of the kidney, of the nephron, which is called the glomerulus. And this can lead to a variety of different things, including but not limited to protein being found in the urine, as well as albumin, which we want to keep in the blood vessels in order to help keep blood in our blood vessels. Our final topic is aneurysms and dissections. An aneurysm is where there is dissection of or outpouching of a vessel wall, so it balloons out. Now, this can happen in a vessel, but it can actually also happen in a cardiac chamber. We know our chambers are called the ventricles as well as the atria, and they can balloon out, and if they balloon out, they're not going to be functioning as well as they should. And the most common location, and I reviewed these vessels in our lecture, is the thoracic and abdominal aorta. And these are very serious issues if they do occur. This is showing you the abdominal aorta that has an aneurysm. There are two types that we'll talk about briefly on the next slide, a true and false aneurysm. Causes, obviously, atherosclerosis. Those with high blood pressure are also more likely to have weakening of the walls because the pressure is so high within the vessels. And then there are some cases, so those would be considered acquired over time. There are some cases that are congenital. We also talked about this last term, where you can be born with an aneurysm that doesn't rupture until the age of, say, 50 or more. Types of aneurysms. All I want you to know from this slide is that we have a fusiform circumferential and a fusiform saccular form of an aneurysm. And this is a true aneurysm where you have ballooning, and make note of this, please, of all three layers of the wall. So different terms here, but we have the tunica internal layer, then we have the media layer, the muscle, and then the adventia, which is just that external layer, the tunica externa. So with fusiform circumferential, you can see the ballooning occurs throughout really the circumference of the vessel, whereas fusiform saccular is just one side where you have this sac that protrudes. A false aneurysm is a bit different. This is where there is an extravascular, so outside the vessel, hematoma. So it can look like an aneurysm, but it doesn't behave like an aneurysm. And this here is showing you a dissecting form. And you can see the dissection or the tearing of those two inner layers, the intima as well as the media. And so just please remember that a true aneurysm really does affect the three layers of the vessel wall. In terms of complications that can occur, some of this is pretty obvious. You can get blood that is seeping in between layers, or it can rupture entirely, or it can get so big that it blocks the normal movement of blood. You can get clot formation. I mentioned this earlier, that when blood is moving turbulently through a vessel very violently, it can continue to damage the endothelium, causing clot formation in that area. And then everything that we know with clot formation can occur from there. Hemorrhaging, if it ruptures, it's a very, very serious event. And then ischemia, if you have an aneurysm present, it can affect blood flow distal to distal, so distal from that aneurysm. Okay, that's the end of this catch-up lecture. Thanks for your patience. Bye for now.